Okay, welcome back. Part 3. Let's finish this thing up. All right, hypersensitivity reactions. So any sort of exaggerated immune response or inappropriate immune response counts as hypersensitive. Really, any reacting to anything that we don't really want it to. So there's going to be two parts. Hypersensitivity reactions don't just happen. We mentioned this at the beginning. This is always going to be part of the adaptive immune system. So you won't ever have, let's say that you're allergic to, sulfa. The first time you ever have sulfa, there's no response to sulfa. That's your first contact with the antigen. That sensitizes you to an allergic response with sulfa. You form memory cells, you form antibodies. So now if you have a sulfa a second time, that's when you're going to have a reaction. So if you ever had a reaction to sulfa, it wasn't your first time. It was the second or more times that caused the reaction to happen. So there's 4 different ways a hypersensitive reaction can occur. The first one is, sort of classic allergies. IgE mediated, mast cells releasing histamine. So here I have a histamine, I have a mast cell, and it has all of these IgE antibodies on it, and something like, pollen or, I have a peanut allergy, peanuts bind to this. They cross-link the IgEs, and then my basophils, and more importantly, my mast cells, because remember, those are the acute response, are going to degranulate, release histamine, and that's the immune response. This is really fast. Allergies, anaphylaxis, which is really just a systemic allergy, it is going to be really quick. Type 2 is going to be antibody mediated, so IgM or IgG. Specifically an antibody. So here's a normal cell minding its own business. This is a normal cell. It's not a bad cell. It's often a red blood cell. And maybe an antibody comes and binds to, maybe it's like the B sugar, some antigen on the exterior of the red blood cell or any cell. So this is a mistaken antibody. It thinks that this cell is bad and harmful when it's really not. It's a friend. It's not an enemy. Other cells then, going off the bad intel from the antibody, will go ahead and start shooting missiles to try to kill that cell. And so this is how the immune response, the antibody is telling the rest of the immune system, hey, this is a bad thing, when it's actually not a bad thing. So the antibody is initiating everything. These are all going also in terms of time. Type 2 is longer than type 1, type 3 is longer than type 2, and type 4 is the longest. So for type 2, this would be transfusion. I said it often is with red blood cells. Hemolytic anemia, so maybe for your own red blood cells. Rheumatic fever, and myasthenia gravis would be another example. Type 3 is immune complex deposition. So antibodies will bind on to an antigen. And maybe complements will also get in this mixture as well. There's a couple different ways this can happen, but some sort of mixture of antibodies and antigens and complements. Basically, it's floating around your blood. And I mentioned that often it's your spleen's job to eat up those complexes and get rid of them. But sometimes, for whatever reason, that just doesn't happen. And so these immune complexes can then deposit random places in your body. And that's where we had that picture of the garbage that we saw earlier. This is why we can't have nice things. So there's garbage everywhere. That garbage is the immune complexes, and that pisses off your neutrophils. And we said that the neutrophils, try to blow shit up when they're attacking people. And so they're going to make things even worse. Often these immune complexes are going to deposit in the joints. So rheumatoid arthritis, SLE, systemic lupus erythema is going to be caused as well. Also serum sickness, which we'll talk about. And then type 4 is going to be our T cell response. So this is the only one that is not related to antibodies at all. This is going to take the longest. So this is often called a delayed hypersensitive response. And it's really anything with the skin. Rashes, Stevens-Johnson syndrome, which is a response to epileptic medications, fixed drug eruption to like sulfa or something like that, poison ivy, PPD, purified protein derivative, the tuberculosis skin test. So let's go through all of these a little bit more slowly now. So type 1 is I have inappropriate preformed IgE antibodies on a mast cell, like shown. So this is my mast cell. Could be basophils, probably mast cell. Here's my IgEs. And then some allergen, whether it be a peanut or pollen, is going to cross-link them, and then it causes degranulation. So the release of this, this histamine, serotonin, we said are going to be vasodilators. Heparin is going to be a blood thinner, so more blood's going to come in. We're also going to have our eicosanoids, the leukotrienes, the prostaglandins, is more vasodilation, more blood vessel becoming permeable, and and so that's why somebody might become red. It's because all of that blood is rushing into the tissues there. In general, anaphylaxis is when we have a systemic type 1 response. And think about vasodilation, kind of like Boyle's law. If the volume goes up, the pressure goes down. It's more complex than that, but that's a fun way to simplify it. If you have your entire body, the blood vessels dilate, that means your pressure is going to go dramatically down. This can cause shock. People go into anaphylactic shock, super low blood pressure can kill you. This is countered by epinephrine for one reason being that it constricts your blood vessels, and that's going to raise your pressure back up. So we talked about this. Itching is also another classic symptom of histamine. Histamine is going to cause your bronchioles to constrict as a result of the smooth muscle contraction. Well, if they constrict, it's harder to get air in and out, so you go into respiratory distress. This could also kill you if the anaphylactic shock doesn't kill you. But epinephrine helps with this as well. So it also dilates your bronchioles. So epinephrine, that's why people carry EpiPens for both the vasodilation hypotension issue and for the respiratory distress issue because it dilates your bronchioles. Also, atopy is just a genetic predisposition to be hypersensitive type 1. So to overproduce IgE antibodies inappropriate, basically. Type 2. We said this is where antibodies are falsely accusing somebody of being bad, and then the rest of the cells just being normal kind of go off of that bad intel, and so it's going to be IgG and IgM, and so they're going to stick to this cell. So this is a wrongly accused cell. Again, it's often a red blood cell, and then they're sticking all over it to some antigen, which they think it's a bad guy, but it's not a bad guy. And as a result, the macrophages and the neutrophils, I'm kind of surprised to see an eosinophil because that usually responds to IgE we mentioned, but we'll ignore that. And natural killer cells. All of these cells are going to go ahead and kick the crap out of this cell because they think it's a bad guy, but it's not really a bad guy. To test for this, again, often it's red blood cells, so you can do a Coombs test, which is looking for antibodies directly on the surface of a red blood cell. Or you can do an indirect Coombs test, which is just looking for antibodies that are floating around the serum in general. Type 3, so antigen-antibody complexes, complexes, sometimes with complement complexes, deposit in the tissues, often in the joints. This attracts neutrophil. Neutrophils are like the Team America World Police, right? They're trying to destroy the terrorists in Paris, but they blow up the Eiffel Tower. So we have these complexes deposited in our tissue. That's already bad, but then it gets even worse because the neutrophils come in and go, we'll destroy this, and it goes bam, 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 and it just starts screwing everything up. There are two different ways we can look at these. One is it's called a serum sickness. So, by the way, lupus and rheumatoid arthritis common. So serum sickness, this would where you have antibodies to foreign proteins. So maybe you're injected with a monoclonal antibody or an antitoxin or something, and then maybe like 1 or 2 weeks later you get really sick as a result. That is serum sickness, and it's a systemic issue. On the other hand, we have something called the Arthus reaction. So this one might be if I'm getting a booster shot, so that meaning I've already had a couple before. There's a subdermal injection, and this, rather than being a systemic, it's a rapid local immune response. So it's going to specifically just cause inflammation, potentially necrosis and edema of the injection site. So if we're looking at this here, I have preformed. So we've injected, maybe this is the booster particles that we're injecting, and I have these antibodies preformed that are pissed off, and want to attach to this thing. So they'll form these complexes, and rather than, again, going into circulation, which would be more of a serum sickness, immediately my cells start recognizing them, causing inflammatory response, etc., and that's why you get this. So type 4, 4 T's, transplant, T cells, touching, and tuberculosis skin test. But I think the better way to think of it is just anything to do, definitely the T cells, but anything to do with the skin. So on the note of T cells, this is, we could have a Th1 cell, which is going to promote the cell-mediated response. So that the CD4 basically is releasing cytokines, causing inflammation. We have a picture of this here. and just inflammation, and the macrophages and the neutrophils are going to go crazy, just start attacking random stuff. On the other hand, rather than a CD4 Th1 cell, it could be a CD8 cell that inappropriately recognizes something, and then it just goes door to door, killing that particular thing. So obviously, both of these scenarios are T cell responses. They're both inappropriate, which is why it's a hypersensitive reaction. They're very delayed, and it's the only hypersensitivity reaction that doesn't require antibodies, which makes sense because this is a T cell response in particular, so we shouldn't have any antibodies. Just a classic example is the PPD test. If you've had tuberculosis before, we are going to inject some of this protein into you, and you should have antibodies. I guess you might have antibodies, but again, it's mostly T cells. You should have T cells that recognize this. And after a day or so, you should have a large bump, basically, which is just a sign of like a large amount of inflammation going on. Now, if you've never been infected before, then you don't really have that much memory T cells for the tuberculosis protein, and so you're not going to have much of a bump. Transplants. All right, a bunch of different ways we can have transplant rejection. So I just want to point out 1, 2, and 3. These are rejections, and this is the opposite. This is the transplant organ rejecting you, basically, the donor organ rejecting the host. So the hyperacute minutes. So this means I gave somebody a new, I think the kidneys are the most commonly transplanted organ. So I give somebody a new kidney, and for whatever reason, they already had, they didn't even get a chance to know it. They just already had antibodies that said, we hate your guts, and they were ready to go, ready to attack it. That's a type 2 hypersensitivity, where antibodies are starting everything off. And this might be if there's like a blood type mismatch. You might have antibodies already, if you're blood type A, you have antibodies for blood type B, and if someone gives you their kidney, there's going to be a lot of red blood cells that are, in that organ, and those are going to get attacked. But it could be other things. It doesn't have to be the blood type. Now, the antibody response will cause coagulation. It will occlude the vessel, will cause a thrombosis, and so you'll have necrosis and ischemia of the thing. But for a lot of these questions, they're going to have you figure out what type of rejection it is based off of the histology. So we're going to look for the thrombosis and the necrosis. For the acute, so this is acute, not hyperacute, so it takes a little bit longer. So it's weeks to months. Now you can. So in a hyperacute, they're going to put in a new kidney, and they're not going to sew you up right away. Maybe they'll wait like 20 minutes, something like that, just to see how you respond. Is it attacking it right away? If you have a hyperacute response, they're going to take that organ out. They're not going to leave it in. On the other hand, acute, well, it's too late. We've already sewn you up. You already got that kidney. So I guess we could take it out, but it's a pain in the ass. So instead, we usually deal with these by just, giving immunosuppressants. You usually give prophylactic immunosuppressants regardless. Maybe you'd give more immunosuppressants, but ideally, hopefully, this would cut down on the response. So specifically what's going on here is we're attacking the foreign MHC molecules. Again, we said that like the smell and the attraction of, somebody of a different HLA type, there's a lot of diversity. Well, that also means it's really difficult to match up the HLA types because you're not just matching up HLA, you're matching up HLA, HLA-B, HLA-A, HLA-B, HLA-C, and the DR, the DQ, et cetera. I mean, there's a lot of things, and then we're diploid, so it's really difficult to get a perfect match, try as we might. It's easier to match up blood type than it is all of the, MHC molecules. So usually you'll be a match for somebody, maybe not a perfect match, unless you're identical twins. This is a humoral response and a cell-mediated response. The humoral would be type 2, and the cell-mediated would be type 4. And the histology thing to note, the high-yield thing, is that there are lymphocytic infiltrates for an acute rejection. Chronic is chronic. It's going to be longer. It's going to be months to years. Again, you can cut down on this with immunosuppressants. And this is CD4 cells, which would be a type 4 hypersensitivity, not responding to the MHC, but donor peptides that are being presented on the MHCs, we're going to recognize as foreign and attack that. And this is going to lead to, the high yield thing is to know that this causes fibrosis and arteriosclerosis. Graft versus host is, often if you're donating a bone marrow or a liver as an example, so the bone marrow and the liver, these have a lot of B cells and T cells already ready to go. So when you donate the bone marrow, when you donate the liver, these B cells and T cells activate, and they suddenly find themselves in a strange land where tons of foreign stuff is around. So they start going crazy, attacking everything. And this causes multi-organ dysfunction, and often these things will even invade the new bone marrow, the new stem cell niches, and now you have permanent denizens, the foreign denizens in your body that are just constantly producing B cells and T cells that hate your guts and are attacking you. Jaundice, diarrhea, and a big rash are going to be common for that. So again, hyperacute is going to be that you had antibodies ready to go. They were already circulating, and they just say, hey, we absolutely hate this friggin' organ. And so you got to take it out. It's not a successful surgery. And then what we're looking for is that we get thrombosis, potentially necrosis and ischemia of the tissue. Acute would be the next one. This is going to be weeks to months. And this is against the MHC. So we have CD8, we said it's humoral and it's cell mediated. So I have a CD8 cell and I have an antibody cells, and they're both recognizing these foreign MHC molecules. Whether it's in the endothelial cells or in the parenchymal tissue, it's not important. It's just recognize the MHC, and it's both humoral and cell mediated. And our big thing is lymphocytic infiltrates. Chronic is not attacking the MHCs, but the donor peptides that are presented on the MHCs, we're now attacking that. And remember, this is a CD4 response, and it leads to fibrosis and arteriosclerosis. This is a blood vessel, and now the blood vessel is very thin because of the fibrosis. All right, graft versus this should be graft versus host, we said that this is the B cells and T cells from the donated organ that now just go throughout the entire body and just start destroying stuff and cause jaundice, cause rashes, GI issues and whatnot, and they can settle into your bone marrow and your niches, and then now you have permanent. In your lymph nodes, permanent cells that are going to attack you. That's why this is chronic. This isn't the chronic one here, but it is often a chronic issue. Autoimmune disorders. All right, two broad categorizations. I also want to give a little disclaimer. Some of this stuff. So I think all of this is pretty fair game. I think some of this might be lower yield. So this stuff here, you might not need to know as much as I get into. It's hard because they talk about it a little bit, but then they talk about it later in other sections too. So maybe take this with a grain of salt. Also, vasculitis, I didn't talk about much, and you guys might have to know more than I mentioned. So let's jump in. So these are going to be joint pain, and this is going to be muscle pain and weakness. So rheumatoid arthritis, we said this is a type 3 hypersensitivity. We have immune complexes in the joints. Specifically, this is going to be the metacarpals. Osteoarthritis would be the distal interphalangeal joint. This is the metacarpophalangeal joint. So that's one big thing. It's going to be versus, osteoarthritis would be hard and bony. It's going to be soft, warm, and tender, especially warm. This is just a sign of inflammation. And so is tenderness, also a sign of inflammation. Inflammatory pain is worse when you're resting. It's worse in the morning, but the more you use them, the muscles and get the joints moving, the better it feels actually. And that would be opposite in something like osteoarthritis. And then you have something called the rheumatoid factor. So this is an antibody that targets the FC portion of an IgG antibody. We also have cyclic citrullinated peptide in the joints, and so we have antibodies against that as well in rheumatoid arthritis. And C-reactive protein, we said, is response to IL-6. It's one of our liver's acute phase reactants. That will be elevated. So will the SED rate, the erythrocyte sedimentation rate, which is just another sign that you have some sort of inflammatory immune response going on. I should mention that almost all of these immune things, just generally, they lean towards women. Women are more likely to suffer from autoimmune diseases than males. Now, obviously, that's going to not always be true. That's going to vary from disease to disease, but that it's a decent heuristic to operate off of. All right, lupus, SLE. So you're going to have heart valve issues, renal issues. We'll talk about those more in later sessions. This is a big one. You got this big old butterfly, rash on the face over here. Photosensitivity is another big one. And then there's a bunch of different antibodies that you guys will be responsible for knowing. The antibodies are often going to be a big clue in the vignettes about what somebody has. We said this is a type 3 hypersensitivity, kind of like rheumatoid arthritis. But this one is especially going to be associated with a complement deficiency. Remember that you need the C3b to clear the immune complexes in the spleen. Otherwise, they'll just keep floating around and eventually get trapped, and we have all that garbage throughout the body. Scleroderma, this is just going to be systemic sclerosis. So you have fingertip pitting, pulmonary fibrosis, scarring of the heart. And now there's two different subsets. We have a diffuse one, and this is just the skin involvement it's going to be widespread. Also know that we have a topoisomerase antibody, anti-SCL70 for the diffuse one. Now the limited one's probably more important to know, and this is what's associated with the CREST syndrome. So C stands for calcinosis cutis, which is we get these swollen, hardened fingers over here because of calcium deposits. So there's really a lot of C's. They all play into it. And also we have an anti-centromere antibody for the C. Raynaud's we'll talk about in a hot second. This is basically your fingers get really sensitive to the cold and it gets painful. Your esophagus, gets fibrotic, and so it's difficult. The peristalsis, dysmotility ensues. And sclerodactyly, it's kind of in response to the Raynaud's. So Raynaud's, you're not getting enough blood flow. And so that's going to, cause ischemia, necrosis of cells, in the distal parts of your hands. And your body trying to repair that damage starts sending in fibroblasts to repair it. And this now you don't want too much, fibroblasts depositing collagen and stuff. It causes your fingers to harden and curl. And so that's what we were looking at here. And then the telangiectasias shown here. Raynaud syndrome, so it's associated with scleroderma, also associated with lupus. And so I always thought of SLE, and then I noticed there's another SLE. So the SLEs cause Raynaud, and then you can think of that stands for snow. So the cold limits blood flow, and it does this specifically in the extremities, in the toes, but especially in the fingers. And so, someone might have normal hands and then they get blue and they're low in oxygen, and then blood surges back in and they become red. And again, this gets damaged in this scenario and is tried to be fixed with the sclerodactyly. And that, makes things worse, causes this. Seronegative spondyloarthritis diseases. There's going to be 4 of them: psoriatic arthritis, ankylosing spondylitis, inflammatory bowel syndrome, Crohn's, and ulcerative colitis (UC), and then reactive arthritis. So there's seronegative, meaning it's difficult because there's not a lot going on in the plasma to detect. So there's no rheumatoid factor. Sometimes the SED rates and the CRPs are normal as well. Sometimes they're elevated, but sometimes they're small. There's a HLA-B27 we mentioned earlier. This one's really very telling for this. Back pain especially. So arthritis, for rheumatoid arthritis might be in the knees, but this is really bad in the back, and it's worse in the morning, like most of these inflammatory conditions. Sometimes the Achilles tendons get a little bit inflamed, and you get uveitis, really just inflammation of the eye, and dactylitis sometimes, which is these sausage fingers get a little bit swollen. Psoriatic arthritis, so psoriasis is just the skin condition, and sometimes you get something called these nail lesions. You can kind of see here, these little bumps all over, so the nail lesions. And then the finger and cup deformity is very telling. So this, the joints here, that's like a pencil, and I guess this is supposed to be like a pencil cup. It's not a great picture here, but this is maybe a better representation. Pencil or finger and cup deformity on an X-ray. Ankylosing spondylitis. This one's a little personal for me. I for a couple of years have had ankylosing spondylitis, and it friggin' sucks. So this one is especially painful on the back, and it just causes your spine to slowly over decades fuse together. Is there's lots of, it damages it and it repairs it, and it damages and it repairs it, damages and it repairs it, and people get this bamboo spine. Sometimes it can inflame your costosternal joints, making it a little bit hard to breathe. We mentioned that for a lot of these things, they will cause enthesitis, so inflammation of where the tendons insert, especially the heels and the Achilles. This can cause pain. And one way you can remember this is if you think of I have it. I'm a young guy, and I had morning back pain for a couple of years, and this is particularly telling because again, most autoimmune diseases are going to affect women. And this is one that affects men disproportionately. So young male wakes up in the morning with back pain is certainly ankylosing spondylitis. And like all of these seronegative spondyloarthritis conditions, this one is HLA B27 positive. like 90% of the time. Crohn's disease and ulcerative colitis are two versions of inflammatory bowel disease. Obviously, you go into way more detail in this in the GI system. We can probably just leave it at this right now. These are associated, though, with spinal pain as well. So they're seronegative spondyloarthritis conditions. Reactive arthritis, people say can't see, can't pee, can't climb a tree. Can't see because you get conjunctivitis. So it makes vision an issue. Urethritis, this is going to be difficulty. Your urethra gets inflamed, and so it makes it difficult to pee. And then arthritis, especially of the knees, just the idea is it would be difficult to climb a tree if you had arthritis like this. Now, this is usually an immune response to somebody had some sort of bacterial infection or an STD or GI or whatever. It could be in response to like a weird response to a vaccine, but it's more likely going to be a bacterial thing. And fun fact, reactive arthritis, sometimes called writer's arthritis, so that confuses you. The name fell out of practice because Reiter was like a Nazi who committed a bunch of war crimes, and so they thought, all right, let's rename this reactive arthritis. And the idea is it's reactive to the infection. It's reactive to technically what this is molecular mimicry. So let's say you get an infection with Yersinia. And Yersinia has some antigen on it. And so you start producing a bunch of antibodies and you have a bunch of T cells that now recognize their soulmate, or at least they think it's their soulmate. That's the Yersinia, the antigen there. Eventually you clear the Yersinia infection. But actually, as it turns out, there's another protein in your body. I don't know, maybe some part of your collagen, which actually might look really similar to this Yersinia antigen. And so now you have all of these T cells and B cells, and they're supposed to be for this, but the soulmate thing's a little bit of a load of crap because, they're actually the collagen is similar enough that they start attacking the collagen now. And then it's a self-reinforcing cycle because the more they attack it, the more they divide and form memory cells. And that's one of the reasons that autoimmune conditions they can't be cured and they're progressive. They just get worse as an individual gets older because they form more and more. You have that, all of the things that we thought were good, like the somatic hypermutation, the affinity maturation, are just going to amplify and make the problem worse. So this is molecular mimicry where an endogenous self-antigen is molecularly mimicking. It's very similar to some pathogen that has infected you. All right, antiphospholipid syndrome. People can get a false positive for venereal diseases. A couple different things: anti-cardiolipin antibodies, lupus anticoagulants, and a beta 2GP antibody as well. This is associated with blood clots, spontaneous abortion. That's going to be a high yield on the vignettes, and thrombosis are associated with this. Fibromyalgia. So don't ask me why, but it's women who suffer from depression of childbearing years. So usually like 20 to 50 have fibromyalgia. It's difficult to diagnose like the spondyloarthritis conditions because it's seronegative. People are extreme fatigue. Sometimes they say that they have brain fatigue. The brain feels a little bit fuzzy. Generalized stiffness and soreness, and they have tender points, all throughout their body randomly. So woman childbearing years is depressed is a big giveaway. Sjogren's disease, autoimmune destruction of the exocrine glands, so specifically salivary and lacrimal ducts, so that the tear ducts. You'll have a dry mouth and dry eyes. The dry mouth, I guess there must be some feedback mechanism that the parotid gland's supposed to help create saliva, and if you're not doing it, I guess maybe it gets stimulated extra and it grows, and so you get this parotid gland enlargement. For the lacrimal function, I always thought of from The Holiday, Cameron Diaz. One thing about her character is she has trouble crying. And it's supposed to be like, she's just not in touch with her emotions, but you could just imagine as easily that she has Sjogren's disease. And you'll have all of these fun antibodies for Sjogren's. Polymyalgia rheumatica. So we're kind of starting the ones where I think these might be a little bit lower yield. Morning pain and stiffness, proximal muscles, shoulders, hips. People will complain that it's difficult to get dressed. And there's no actual muscle weakness if you test it. And because there's no muscle destruction, there's no muscle weakness, and the CK levels are going to be normal. Now that the SED rate might be up, and this is very classically associated with giant cell temporal arteritis, which is a type of vasculitis which affects the temporal artery, in your head. and it's going to be associated with unilateral, eye pain and headache. Polymyositis and dermatomyositis are very similar: morning pain and stiffness. But people are going to complain about getting dressed. The difference is, one of the many differences, you have muscle weakness in this case. And because muscle weakness, that's because muscles are being damaged. And if they're being damaged, your CK levels go up. SED rate might also be up. You have all of these antibodies present. And now to differentiate polymyositis versus dermatomyositis, CD8 is going to be for poly. I think of 8 is mini, so that's poly. And then the CD4 is going to be for the dermatomyositis. This is going to affect the endomysium of the muscle. This is the paramysium of the muscle. And derm. Derm is skin. And so for the dermatomyositis one, you're going to have a skin rash that you will not have in polymyositis. So again, I apologize. You guys might not have to know this. I'm not 100% sure. But this is an autoimmune thing, so I thought I might cover it. So this is a good cheat sheet. If you're having trouble remembering all of the many different antibodies, this is a good cheat sheet and has a little bit of fun facts about them as well. Myasthenia gravis and Lambert-Eaton. These are just going to affect neuromuscular junctions and cause muscle weakness. Both of these are type 2. Their antibody, initiates the process. It wrongly, falsely accuses somebody. So the myasthenia gravis is going to go for the receptor. Acetylcholine can't bind to the receptor. It's harder to contract the muscles. On the other hand, you could have, here's my antibody on the receptor. On the other hand, I could have something on the presynaptic calcium channel. Well, remember, calcium has to flood into the nerve terminal to cause exocytosis of the vesicles with the neurotransmitters to get acetylcholine into the gap. So this makes it harder to release acetylcholine. So it's going to cause like a pretty similar phenotype, clinical presentation of the muscle weakness. Goodpasture syndrome. Antibody specifically against the basement membrane. So this is just a small, thin layer of extracellular matrix. Now, specifically, this is going to affect the kidneys, can cause nephritis. And if it's affecting the kidneys, it can cause blood in the urine. It can also affect the lungs, the basement membrane there in the alveoli. And this can cause somebody to, basically puke up blood. And multiple sclerosis, so specifically attacking the myelin of the central nervous system. Your eyes are highly myelinated, so it's going to cause vision issues, optic neuritis, balance issues because your cerebellum is highly myelinated. Neurogenic bladder. You similarly, the specific neural pathways that connect to your bladder, highly myelinated. So neurogenic bladder means that you feel like you have to go to the bathroom all the time, and I guess you sort of do because you can't fully evacuate your bladder because of the ineffective, incomplete communication. So you just pee like a little bit, and so you constantly have to pee because you're not peeing the full amount. So frequent need to urinate, and this one is actually young women specifically. And I have this picture here. So here's the myelin being damaged. Here's normal myelin. Heat exacerbates the symptoms, and I googled young woman who has to pee, and this came up. And this is just to remind you, it's a young woman. They're going to have to pee. That's a common symptom. And she's holding her head, and that's because this affects the central nervous system. So hopefully this is not something I have to explain if my girlfriend happens to see my Google search history while I was looking that up. Diabetes type 1. This is going to be autoimmune destruction of your beta cells in your pancreas, and now you have a harder time producing insulin. Graves and Hashimoto's disease. These are going to be antibodies that attack your thyroid. In Graves, they weirdly stimulate it, so you produce more of your thyroid hormones. In Hashimoto's, this does more what you would think. This sort of destroys and inhibits your thyroid from doing its job, and so you're going to have underactive T3 and T4. Celiac disease, you have a hard time with gluten, so you don't absorb nutrients as well. Inflammatory bowels, these are going to be the large intestine, so differences there. Vasculitis, again, you might need to know more about vasculitis than I talked about, but it's hard to say because you do it a little bit at the end and you do a little bit in the cardiovascular, so I'm not sure. So ask your friends. A bunch of different types. Some of them affect the large vessels. Some of them affect the smaller vessels. Some of them affect the medium vessels. And, there's a lot to know there. Because it's attacking the blood vessels, they're going to get inflamed. Plasma is going to leak out into the interstitial tissue. It can cause purpura, and which is just kind of like larger versions of petechia, something like this. And, giant cell temporal arteritis is maybe the main one. Your temporal artery becomes inflamed, which causes a headache and can also cause vision loss as well. All right, immunodeficiencies. So there's B cell, T cell, and then mixed, and then we have our phagocyte dysfunction. So we'll break them up this way. So for B cell, again, B cell is going to be humoral, and that's going to be bacterial more than anything. Again, not if it's a tuberculosis, not if it's a listeria, because those reside inside of other cells. So that would be the cell-mediated T cell response. Start with Bruden. Bruden is X-linked, and this is A-gamma globulinemia. And A-gamma, globulinemia tells us that we don't have a lot of immunoglobulins, not a lot of antibodies. So your beta cells have trouble maturing, and so this makes the beta cell count go down. Specifically, this is because we have an issue with our Bruden tyrosine kinase, which somehow has a role with the light chain incorporation. Again, this is X-linked, as we see in the name. And someone will be fine for the little baby is fine for the first 5 months. But again, IgG is going to be, that's probably the most important isotype antibody to have in your plasma. And after 6 months, it goes bye-bye, and then the baby has a hard time producing it. So then they'll get, all of these things I'm not mentioning obviously cause tons and tons of infections. The reason I don't mention it for every one of them is this just doesn't help you differentiate one thing from another. Any sort of immunodeficiency is going to cause, excessive infection. So, I'm trying to help you get the right answer. And if everything causes infections, then that's actually not helpful to differentiate them. IgA immunodeficiency, this is actually very common. IgA is going to be in the mucus, so that's GI, and in the airway. And because you don't have a lot of IgAs, if you got a blood transfusion, and most people are going to give you blood, there might be a little bit of IgA in there, and your body doesn't really recognize IgA because you don't really produce it, and so your body might recognize it as foreign, attack it, and then that could cause systemic inflammation, type 1 response, which is known as anaphylaxis, and we say that could cause anaphylactic shock. Because of all of your blood vessels dilating at the same time. This could also cause your smooth muscle to constrict in your bronchioles, and then this makes breathing a little bit more difficult. And weirdly, this can cause a false positive for HCG for a pregnancy test. Common variable immunodeficiency. So this is a bunch of different diseases clumped together, and they call it variable because there's variable, clinical presentations in terms of the phenotype severity. But similar to this one, it's a beta cell differentiation issue. Now, for reasons I don't really understand, the cell count is actually fine, though. So you create B cells, but they just can't fully differentiate, and so they can't really produce antibodies very well. Difference, though, between these two is that this one is diagnosed after puberty, and we said that this one is going to be, at like 6 months. T cell immunodeficiency, this is going to be more fungi and viruses. Thymic aphasia, so you don't have a thymus. DeGeorge syndrome. And DeGeorge syndrome is specifically a failure of the third and fourth pharyngeal pouch to not properly develop. So there's going to be a lot of congenital issues with this. So you will have a bunch of cardiac defects. You'll have congenital defects, including a cleft palate. So here's our cleft palate over there. And you either don't have a parathyroid or your parathyroid's not fully formed. Parathyroid creates parathyroid hormone, which is going to raise your calcium levels. And so if you don't have this, then you're going to be hypocalcemic. So this is all catch-22, CATCH22. And then the main one, thymic hypoplasia. So we don't have a thymus. So way back when, remember we said that you have your the paracortex of your thymus. If you get sick, you get swollen lymph nodes. That's your paracortex being enlarged. But it's the paracortex that is underdeveloped if you have DeGeorge syndrome. So sometimes they'll say a thymic shadow, and that's because when they do a chest X-ray, CXR, there's a shadow where the thymus should be, right around in your chest region. IL-12 deficiency. Remember, I think of the one as being for Th1 differentiation. Th1 is the cell-mediated response. So it goes and kills cells that have viruses, cells that have cancers, but importantly, what else lives in cells? Tuberculosis, a mycobacteria. So you might get mycobacteria infection like a tuberculosis. So somebody, tuberculosis is going to give them problems, but the BCG is a tuberculosis vaccine. In general, it's upper respiratory tract. There's actually evidence that it might confer some resistance to COVID, but mostly this is for tuberculosis. And it's a live attenuated vaccine. So if you have an IL deficiency, you make these chronic granulomas and maybe it'll reactivate. So it could cause somebody to present with an issue after BCG if you're IL-12 deficient. Job syndrome. So the book of Job is God's testing this. Seems like a super nice guy, but God's just testing his faith, and he kills his whole family, and he takes his job, and he gives him all of these horrible sores all over his body. And these people have sores just like that, so they call it Job syndrome. So hyper IgE, so that tells you absolutely we have increased IgE, and what goes with IgE? We have increased eosinophils as well. Decreased Th17. So this one's just kind of random. I can't really think of the link between these. Th17 is caused by a STAT mutation. And one of Th17's job, if you'll remember, was that it causes CD4 cells to become the Th17 T helper 17 cells, and that causes facilitates neutrophil recruitment. So we're going to have less Th17 cells, less neutrophils, randomly more IgEs and eosinophils. And now Job. So Job, there's a big rash, and you have these skin abscesses, which are very cold upon touching. Chronic mucocutaneous candidiasis. This is a fungal infection, candidiasis. It especially causes oral thrush. So we see this often with HIV patients, but if somebody has a defective air gene, they can't deal with this as well. And so, the candidiasis makes a comeback. We didn't mention this earlier, but the air gene, it actually plays a role when you go to the thymus. So cortex, remember, is positive selection. Do I recognize an MHC or not? If so, the T cells make it to the next level. And then the medulla, it's negative selection. We're testing them, saying, do you recognize this antigen? What about this antigen? And the things we're presenting are things like collagen, things that are benign and should be natural in the human body. What plays a role in that testing of do you recognize these things that are actually our own antigens are the air genes. So if you have a defect in air genes, you might have an autoimmune disease, and then randomly it's also associated with this as well. A B and T cell immunodeficiency, SCID, severe combined immunodeficiency syndrome. So similarly, absence of a thymic shadow, we don't have a thymus when we look at an X-ray. So these are the two things that are going to cause a thymic shadow, this and DiGeorge syndrome. I would say that the major way of distinguishing this is that this is going to cause a lot of other congenital deficiencies. Cleft palate, the hypocalcemia should be a big giveaway to differentiate between DiGeorge syndrome and SCID. So three different ways we can get this, three major ways, is an IL-2 receptor deficiency. So let's recall what IL-2 does. This is causing a Th1 cell will release this, and it causes just growth of our natural killer cells, of our CD4 cells, of our CD8 cells. So the T cells are going to grow, and we're going to have a deficiency of this. And remember, the T cells are in the paracortex, so this all kind of makes sense that our paracortex is going to be a little bit underdeveloped. This is going to be X-linked. And another way is adenosine deaminase deficiency. So adenosine deaminase helps break down ATP. Which is our nucleotide. And if we can't break down ATP, that means we have a high level. And then it seems like, why would having a high level of ATP be bad? Well, it actually turns out if you have a really high level of ATP and you're not necessarily using it for replication or, you just, if you have a high level, ribonucleotide reductase, too high a level of this will inhibit that. So basically, I can't make... I can't reduce my ribonucleotides, which means I can't, make DNA, which means I can't do DNA replication. And lastly, RAG mutation. RAG is necessary for VDJ recombination, so you'll have a deficiency there. All of these will lead to SCID. And just failure to thrive. The kid almost certainly needs a bone marrow transplant. Some sort of medical treatment. It's very bad news. Ataxia telangiectasia. This is autosomal recessive. We talked about this in biochem. There's a lot of A's in here. That helps remember it. So ATM is going to recognize DNA double-strand breaks. And so if you can't repair your DNA double-strand breaks, you're going to have a ton of mutations and chromosomal rearrangements, and that's bad, which means you're photosensitive. You cannot deal with UV rays because it damages your DNA, and well, you don't have this, so you can't really fix it. Ataxia, well, that's in the name, and it's an A. Spider angioma, these telangiectasias, we saw one on someone's face earlier. You just have these sort of inflammation of your superficial capillaries. And then the IgA deficiency is one of the reasons this is under a immunodeficiency syndrome. Hyper IgM, so specifically is CD40L. So I've been a dead horse here with this, but it's important. What does CD40 do? CD40 helps power up cells, right? A B cell, a plasma cell, makes macrophages work harder, makes dendritic cells work harder. But let's focus on the B cells. It causes B cells to power up, and one of the things that happens when they power up is they do class switching, isotype switching. So if your default is IgM, and well, if you have a CD40L, the CD40L is on the T cell, and the CD40 is going to be on the B cell. You cannot make the other isotypes, which means you have a ton of IgM by default. And you're not going to have really germinal centers because you have a hard time, powering up your B cells with the T cells. This is X-linked, and then Wiskott-Aldrich syndrome. If you guys remember from Molex Cell from undergrad, the WASP gene codes for a protein called WASP, which just helps rearrange the actin component, the actin microfilaments. If you can't rearrange the cytoskeleton, when I want to move an antigen to an MHC at the surface of my cell, I have to move it around with my microfilaments. So antigen presentation is an issue, and this causes thrombocytopenia and petechia and bleeding. Phagocyte dysfunction. So Chediak-Higashi syndrome. Basically, there's a lysosomal trafficking issue. So you can't fuse it's kind of, again, a cytoskeletal issue. To fuse the phagosome with the lysosome, we need a functional cytoskeleton. And we can't fuse it there. So you just get these large lysosomal inclusions as a result of not being able to fuse them. And similarly, so we get thrombocytopenia and peripheral neuropathy. Albinism, let's talk about albinism. So we make melanin, and we put it in these vesicles, our melanocytes, and then we have to ship it out. And if we can't ship it over to the keratinocyte, then they don't have melanin and they're not going to have color. So this is why you would have albinism and blonde hair and fair features and like that in Chediak-Higashi syndrome. Leukocyte adhesion defiance, you don't have very good integrins. And remember that your Sialy-Lewis X causes them to slow down, but the integrin causes them to stop. And well, if they don't stop, they can't extravasate, which just means they cannot get past the endothelial cells into the interstitial fluid where the battle is taking place with the bacteria to back up our police cop macrophages. As a result, the neutrophil count goes up. Wait, why would that make the neutrophil count go up? Well, if the neutrophils can't get into the tissue, that means they stay in the blood. And if they stay in the blood, then the count is going to be up. So less neutrophils at the infection means more in the blood. Pus contains neutrophil and is partly made by neutrophils, so you're going to have less pus. Now, this is a very unique thing. Umbilical cord should fall off after like a day after a baby's born. But it turns out neutrophils are partly like kind of gnawn at the umbilical cord to destroy it. And so if you don't have neutrophils, working properly, then your umbilical cord stays around for a lot longer than it's supposed to. Chronic granulomatous disease, I think we talked about this briefly. The first step of, taking oxygen and turning it into a superoxide radical from O2 to O2 minus requires NADPH. This is the first step. And so in this case, I need to borrow H2O2 from a pathogen, from the bacteria, and often that's fine. But some bacteria are catalase positive, which means they can reduce their own H2O2 to water. So here we have a little picture of this. This is my first step. This is the NADPH oxidase. But if this is, and ultimately I want to get bleached so I can throw it at the bacteria. But if I, have this first thing, then oh no, how am I ever going to do this? We can steal the H2O2 from the bacteria and use it against it. But if the bacteria has catalase, nope, we just made it into water. And so crap, we've been thwarted. So you can add a dye to a tube of neutrophils. This is the NitroBlue tetrazolium test, and this dye should turn blue in response to this whole process. And basically, if you have chronic granulomatous disease, then you can't. It's not going to turn blue. You're not going to have a color change. All right, medications. Immune modulating drugs in general. So the most common is definitely going to be NSAIDs and glucocorticoids, like prednisone, and NSAIDs being, Aleve and Advil and things like that. So we use this for, just inflammation, pain, organ transplantation, and autoimmune diseases. So NSAIDs inhibiting COX, cyclooxygenase, and glucocorticoids. Nuclear factor kappa beta, which is a major immune transcription factor. Also phospholipase A2, which creates arachidonic acid from the cell membranes, which we'll talk about in a hot second. Now, the immunosuppressants, less common, but they're still super common. They're just going to be for more, like when I got Humira for ankylosing spondylitis, it was a pain in the ass to go through insurance and to have a bunch of doctors sign off on it. So this is going to be for more extreme conditions. Cyclosporin and tacrolimus both work to inhibit calcineurin. Rapamycin, which is more commonly known as sirolimus, notice the name similarity there, is going to inhibit mTOR. Now, a bunch of myelosuppressants, so suppressing the production of cells in the bone marrow. Methotrexate, this is a chemotherapy drug, inhibits dihydrofolate reductase, which makes it difficult for cells to replicate. Who replicates more than any other cell? Maybe the bone marrow cell. So it's going to disproportionately affect them. Who also replicates a lot? Cancer, which is why it's a chemotherapy agent. Cyclophosphamide methylates DNA, makes it hard to replicate the DNA. Again, affecting DNA replication hurts cancers and it hurts bone marrow. Azathioprine creates 6-mercaptopurine. This inhibits hypoxanthine, guanine, phosphorybyl transferase, which is just a part of the salvage pathway to make more purines. If you don't have purines, you can't do DNA replication. And who does that affect? That affects cancers, that affects bone marrow. So why are these three a little bit different than this last one over here? That's because this affects IMP dehydrogenase, which means we cannot make purines. And you would think, okay, you can't make purines, you can't do DNA replication. Yeah, that affects bone marrow. Why doesn't that affect cancer? It's because this one specifically, it's not a chemotherapy drug because it somehow only targets the lymphocytes, and it doesn't. It somehow leaves most other tissues alone. TNF alpha inhibitors, things like you might have heard of Humira, different biologics. These are monoclonal antibodies usually, which are going to inhibit tumor necrosis factor alpha, which is the first step in the inflammatory response. Hydroxychloroquine, this raises the pH of lysosomes and it blocks toll-like receptors on the beta cells. Hydroxychloroquine, was a debatable thing. Does it help with the COVID? Does not. But it's a malarial medication. All of these are eicosanoids, right? We have the leukotrienes. Remember, we have this for the chemotaxis. And then we have our prostaglandins and PG2 is probably the most important one, and then our thromboxane. So these are our eicosanoids. How does this start? This starts with we have a phospholipid in the membrane. Phospholipase A2 converts that to arachidonic acid, and then lipoxygenase can convert it to a leukotriene, or we could have our COX molecules, cyclooxygenases, convert them to prostacyclins and prostaglandins. All of this stuff is just helping with the immune response. So how do our drugs work? Glucocorticoids, like cortisol and whatnot, and prednisone will inhibit this. So that stops the entire process. We don't get any of our eicosanoids. It also was going to go ahead and inhibit NF-kappa B, which is a transcription factor, which upregulates a bunch of inflammatory related genes. Then we have our NSAIDs. So NSAIDs like ibuprofen are going to be reversible. So these are specifically going to be COX, or I guess not specific. These are non-specific. This is COX-1 and COX-2. Who do we actually want to get? We really just want to get the COX-2. So COX-1 gets accidentally, we don't really want to turn off COX-1 as much. This is going to be, it does a lot of stuff, but mucus production in the stomach is big. And so if you inhibit COX-1, people get stomach ulcers if they take Advil too much. And that's a really common and important question you have to ask your patients. So ibuprofen, Advil is reversible. Aspirin is irreversible. We do not give aspirin to kids. No for kids. Unless they have Kawasaki's disease, which is a type of vasculitis. Why? Well, it might cause them to develop Ray's disease, which is basically just some liver issue where they get super jaundiced. And we have Celebrex, celecoxib, which specifically it's a COX-2 only inhibitor. So it's not going to affect COX-1. It's just going to affect COX-2. So, if you don't want to get stomach ulcers, maybe you'll take COX-2. I think it increases your risk of like clots and heart attacks and strokes a little bit. So, everything's got some sort of downside or trade-off. All right. Tylenol also is going to be a COX inhibitor, specifically in the central nervous system. So that's why Tylenol might be a little bit more helpful with headaches. That's, I guess, debatable. Now, people sometimes take Tylenol to try to commit suicide. And that's because, so here's acetaminophen, here's my Tylenol. We can do this, to process it. But a lot of times the cytochrome P450 enzymes are going to conjugate it so that it can be excreted. And to do this, they use glutathione. So if you take too much acetaminophen, you're going to be doing all three of these pathways, but if we just focus on this one, you're going to be using up glutathione. Eventually, you run out of glutathione. You've consumed all of it. Well, you need glutathione to reduce free radicals. It's really important. So the cure would be N-acetylcysteine. It's the cure to a Tylenol overdose. Glutathione is specifically going to be, cysteine, glycine, and glutamate pulled together. So this just makes more cysteine so that we can make more glutathione, which is sort of like the limiting factor there. I don't know how high yield this is for this test, but I don't know. It'll come up eventually. So we talked about it. Glucocorticoids, prednisone, we just said they inhibit phospholipase A2, so no arachidonic acid. NF-kappa B is just a major transcription factor. So this is a transcription factor for inflammatory related genes, but not if a glucocorticoid like cortisol has anything to do with it or prednisone. And if we don't have this, we don't have the inflammatory genes, we're not going to make as many cytokines. It's harder for the neutrophils then to, and we're not making arachidonic acid, we're not making leukotrienes. The neutrophils can't migrate. And this is the same issue we saw earlier. If neutrophils can't extravasate to where the site of infection is, technically their levels increase in the plasma. And that's because, they can't get to the site of the battle. Other granulocytes like the eosinophils and basophils will decrease though. Cushing's disease, remember, is when you have overactive levels of cortisol. And so if you take glucocorticoids, it can cause the same issue. And so you get this, they call it like the moon phase. So you get this sort of bizarre fat deposition. And I think they call it like a buffalo hump. None of these terms are very nice, but those are the terms nevertheless. You get stretching and striation of the skin. High blood sugar. Cortisol raises your blood sugar. Osteoporosis, avascular necrosis of the femoral head. So the femoral head, often you'll break something there. And so there's something called adrenal insufficiency, where if you're taking prednisone for a long time, you're taking exogenous cortisol. So eventually your adrenal cortex says, I can go on vacation. I don't really need to work very hard because we're just taking, the cortisol, and we don't want cortisol to be too high, so we're going to downregulate. Well, if you suddenly stop taking your medication, now you have dangerously low levels of cortisol. It takes a while for your adrenal cortex to figure out that it needs to ramp up production, and you can get really sick in that time period. All right, cyclosporine and tacrolimus. Both of these drugs inhibit calcineurin, which induces IL-2. Again, IL-2 is for T-cell growth. They do it through different mechanisms, though. Cyclosporine inhibits cyclophilin, and tacrolimus inhibits FK binding protein, also known as just FKBP. Side effects of this, it's very damaging to the kidneys, causes vasoconstriction of the efferent and afferent arterioles. And so if my kidney is not working very well, then I'm probably going to retain more sodium and H2O. On top of that, we just said vasoconstriction. So we have some generalized, hypertension. All of this together is going to cause I just mentioned this. All of this is going to cause hypertension. Hypertension because of the effect on the kidney means more sodium in water, and vasoconstriction. All of this just leads to hypertension. And this is very specific. Gingival hyperplasia is associated not with both of them, not with this one, just with the cyclosporine. All right, so sirolimus, also known as rapamycin, it's, Olamis, Rolimus, very similar names, and that's because the initial targets are the same. It is also going to be FKBP. The difference is rather than going after calcineurin, it goes after mTOR. And this is kind of easy to remember. mTOR stands for mechanistic target of rapamycin. So it should be no surprise that the rapamycin is going for the target of rapamycin. mTOR, you'll probably hear this throughout your career in the literature. This is just about growth within cells. So another reason that this is kind of related to the, tacrolimus is that one's related to IL-2 production through calcineurin. And this one is related to IL-2 sort of receiving the signal from the receptor. But think about this, IL-2 is for growth. And so this is inhibiting, it's IL-2 is pro-growth, so this is going to be dampening the signal. So this is causing a lack of growth. And again, that makes sense if you think about mTOR being pro-growth. And the lack of growth specifically within our immune cells can cause pancytopenia. Methotrexate is a common chemo drug. It mimics folic acid, which inhibits dihydrofolate reductase. So you guys probably remember this really fun thing from the biochem modules. Folic acid through dihydrofolate reductase is made into DHF, which becomes THF, which ultimately helps, add thymidate, which just means add a methyl group on the U to make it a T. Now, sort of the good news, you don't really need to know that. You can just think about methotrexate inhibits dihydrofolate reductase, and if I can't get THF, tetrahydrofolate, I cannot get thymine, I can't get my DNA, and so I can't replicate your DNA. Now, if you cannot, less replication, again, who does this affect more? It affects cancer cells, yay. It also affects bone marrow cells, maybe yay, maybe not. Myelosuppression, so, your white blood cell count, your hematocrit, that's your red blood cell, your platelet count, all of these will be down. And also your GI also replicates a lot. So this will cause GI issues. Probably most of these chemotherapy things will. And then randomly your mouth, I guess there's a lot of division in your mouth cells. This also causes that to be sore. So you might want to, depending on, how bad certain symptoms are, you could technically bypass. You could do a rescue with another medication called leucovorin. So leucovorin can make THF, and it does this skipping over. It doesn't require dihydrofolate reductase. There's a different pathway to make THF. So if you were, if this was so bad that you're now having issues, I guess one question is why don't you discontinue the drug? But I don't know. Maybe you need the drug, but it's working too well. And so then you can have leucovorin, which can come in and allow a little bit of DNA synthesis, which can, allow your bone marrow to function. Cyclophosphamide, again, chemo drug, this alkylates DNA. And so if you had a big, R group on your DNA, you stick these together. I now have dysfunctional DNA. It can't divide. If it can't divide, it's going to affect cancers and it's going to affect bone marrow cells. Bladder toxicity is really big with this. We'll see this again with the hematology oncology section. As this is metabolized, it makes something called acrylane. Acrylane is going to, for whatever reason, specifically damage the lining of the ureters and the bladder. Bladder toxicity is very high yield to know. It also might cause SIADA, so a symptom of inappropriate antidiuretic hormone secretion. What does that mean? Remember, ADH just goes to your collecting ducts of your kidneys and causes more water to be reabsorbed. So you have too much ADH from your posterior pituitary, which means you have too much water reabsorption. Too much water going into your plasma means that however much sodium you have, it's now going to be diluted. It's not as concentrated. That's called hyponatremia. It can cause seizures and lots of other bad stuff. Azathioprine is converted into 6-mercaptopurine, sometimes just called 6-MP. It does a bunch of different things, but I would say the main one is that it inhibits the salvage pathway by competing with the other purines for hypoxanthine, guanine, phosphoribosal transferase. So if I cannot, salvage, I can't make more purines, then I'm going to have less replication. Same old story, myelosuppression, and it's an anti-cancer drug. Now, 6-mercaptopurine is degraded through the mechanism of xanthine oxidase, which might sound familiar because if you have gout, we actually, we don't want to, we want to inhibit this, and we inhibit this with allopurinol. Well, if I inhibit this with allopurinol, now I don't have this. Now I just have these levels build up. And it depends. Depends how much I want to kill the cancer in my body, or I have an immune thing, or it's just something you want to be aware of. It's not necessarily bad, but it's going to be a trade-off. It could be good, it could be bad. So again, azathioprine can turn into 6-MP, which is negative feedback because it competes for this. And now I cannot recycle this. I can't recycle this. I have less purines. All right, mycophenolic acid is a myelosuppressant, but we said it's not a chemotherapy drug. How does this work? IMP dehydrogenase, necessary to make purines. So it turns inosine and it basically just makes purines. To make a long story short, this inhibits that. Okay, it's same friggin' thing. Can't make purines. You can't do DNA replication. That affects your bone marrow. Why doesn't this affect cancer? Because this somehow heat seeks for lymphocytes, so it's gonna leave cancer alone. So don't use it as a chemotherapy drug. All right, a little summary. The cyclosporine goes with cyclophilin to inhibit calcineurin. Tacrolimus goes to FKBP, also inhibits this. This is going to be like a nuclear factor for helper T cells specifically, which is going to upregulate inflammatory things, but no MOS. No calcineurin means no NFAT. FKBP can also bind to sirolimus, also known as rapamycin, which is the rapamycin is now going to inhibit mTOR. mTOR is all about growth, and specifically it's not allowing it to respond to the IL-2, which is the growth of our T cells specifically. And cyclophosphamide, we said, is going to add R groups. It's going to methylate our DNA, which inhibits replication, which affects bone marrow. Glucocorticoids are going to inhibit phospholipase A2, so less arachidonic acid means less eicosanoids. Also, this major transcription factor for immune-related genes, inflammatory genes, NFKB and cytokines is going to be inhibited. Mycophenolic acid inhibits this, it inhibits this, which means less purines, which means less replication, which means less cancer and less bone marrow. Azathioprine becomes 6-NP, inhibits. So it does get PRPP a little bit, but again, the one we emphasized was HGPRT. I don't think it's really important that you can differentiate that. Again, we're going to have less purines, which means affecting bone marrow. And we're going to have, it's going to affect cancer as well. And then methotrexate inhibits dihydrofolate reductase because it can mimic folic acid, and this means we have less thiamine production. We can't add a methyl group to our uracil. We can't make DNA, and that's going to be immunosuppression because no bone marrow, and also anti-cancer. All right, TNF alpha biologics. So these are monoclonal antibodies, at least these two are. So TNF starts remember, this is one of the things along with IL-1 that and IL-6 that a macrophage produces to start the inflammatory response. And so if you stop this, you start a lot of the inflammatory response. So specifically, if you have arthritis or spondylitis or, Crohn's disease, you take an injection. I take an injection every 2 weeks for the Humira drug. And, it ideally goes ahead and, these antibodies will bind to TNF alpha. So, this is very much cutting down an immune system. You could get sick because you can't produce a proper inflammatory response. But it also is the trade-off then is that it stops your autoimmune T cells and B cells from attacking whatever particular tissue. Also Crohn's disease. And so adalimumab and infliximab are going to be monoclonal antibodies which bind to TNF alpha. On the other hand, etanercept is a TNF alpha receptor. So it's very similar, but a little bit different. So it's a decoy receptor. So it also binds to TNF alpha, but it's not a monoclonal antibody. It's just tricking, it's a soluble, free-floating receptor that floats through the blood, and it just binds onto a lot of TNF alpha. and causes effectively the same, same consequence. So I mentioned earlier that you need in this order IL-12 to activate a Th1, and then Th1 produces interferon gamma, and then interferon gamma is going to go ahead and cause macrophages to become empowered, and one of the things they might do is secrete TNF alpha, and that causes a granuloma, which, if you recall, is the little prison for the Titan monsters from Hercules. So things like tuberculosis are going to be trapped because we have a hard time killing them, so we just trap them in a granuloma, and that is TNF alpha mediates that sequestering. So if you go on one of these drugs, you have to be screened to make sure that you don't have some sort of latent tuberculosis sitting within your body trapped in a granuloma. Because if you did, you would take this drug and it would stop the TNF alpha, which means your granuloma would dissolve, which means the tuberculosis would get out and cause a problem. Last but not least, the chloroquines, mainly hydroxychloroquine, is usually used for malaria, but it has a little bit of an immunosuppressant effect too. So the toll-like receptors in the B cells, it will block these. It also, lysosomes are supposed to be really acidic, and it'll get into the immune cells specifically and raise the pH of the lysosomes, which obviously if you're a phagocyte and you try to fuse your phagosome with your lysosome, it's not going to really be very effective. I lied. All right, so obviously we have histamine, and that's for allergies, and so we can take an antihistamine. Diphenhydramine is one of many antihistamine drugs. All right, now we're done. All right, cool. All right, hope this was helpful. Bye.